Benadryl, you may have to give epinephrine. Okay, so those things are important. When you have a patient who has a hemolytic reaction, you also have to send a blood sample and a urine sample down to the lab. But otherwise, all of the tubing, the blood product itself, all of that goes to the blood bank. Because they need to figure out whether there was something that happened at the bedside, meaning that nurses didn't identify the patient, or it could be the citrates that are in there, the preservative, or they need to see if it's something they did wrong in the blood bank. So everything goes back. It becomes like a sentinel event kind of investigation to see what happened with the blood product. Okay? So make sure all of that goes back. You still make sure, big thing though is make sure you document what happened with the patient when you call the doctor, because those kind of things can come back. People get so into it they forget to write that kind of stuff. If it ends up that the patient has a really bad outcome, even if you did everything right, you got to show it on paper. So that's why that's important to do. So make sure that second person is in there identifying the patient. Then we have our acute pancreatitis. Pancreatitis is something that can happen in various patients, but by far we see it most often happen in alcoholics. Okay, so these are people that are drinking a lot, all right, because they don't care about food, they just care about drinking. So you see it in patients with alcohol abuse. It can also be from patients who have biliary disease, who never took a drink. Now, the reason I say that is because there's a lot of nurses that think everybody who comes in with pancreatitis is alcoholic. It's not everybody. It's the majority of them, yeah, but it's not everybody. So it can be from people who have biliary disease. You get stuff stuck in your bile duct and you end up having a problem. It can also be for some medication. Okay? And it can happen at any age. That's the thing. Because I've seen acute pancreatitis in someone as young as 10 years old. So it can happen at any age when you're talking about it happening with patients. Does it happen to older people more? Yes. But know that it can happen in any age of patient. So these are the major reasons why you see it happen. But what happens is an acute infection of the pancreas. Okay. So that you already know it's an itis, so you know it's going to be antibiotics that go with it. Okay. The major complaint that a person has who has pancreatitis is pain. They tell you it hurts, it's killing me, radiates up to my right shoulder, around to my back, I'm gonna die. All right, that's the kind of they're always talking about, because that's their major thing, is always pain. Now, one of the things you got to remember, people keep coming in with a recurrent problem. Remember, pain is what the patient says it is. Although we know there are people who are drug seeking at times, these are people that sometimes, because they have it all the time, will look at you and you're watching TV or talking on the phone and people say they're not in pain. Some people just learn how to deal with stuff when they have it. So yes, there will be some people that are not the most honest people about that, but other people who just learn how to deal with it because they have it all the time. Chronic pain issues are things that some people have. So when you have a person who has this, they've had either some exposure or they finally get to that point where now the alcohol bothers me so much, so you end up having an acute infection of the pancreas. Now when this happens, you have, now the pancreas is weird in the endocrine function world because it has function in the endocrine side, which is the release of insulin, those types of things, somatotrophin, so it has some other stuff that it does in there. And the other side is exocrine function, so it functions in processing fats. So it releases enzymes so that you can actually process fat. So what happens in a patient who has acute pancreatitis is there's some degree of where this inflammation now causes almost auto-digestion of the pancreas itself. So you will see anything that the person eats causes the problem. If they drink water, it causes the problem. So one of the big things you have to do is put the patient on bowel rest. So you don't have them eat or drink anything. And in the first couple of days, you really don't want them to even have ice chips because anything they take into their mouth causes a problem. It causes those enzymes to be released, therefore increasing the pain that the patient has. That's part of the reason why you don't get them to eat. Anytime they're releasing enzymes, that's what's going to cause problems for the patient. So that's problematic for them. And that's something that continues on. Now, some of the other things you're going to see in this patient are elevated amylase and lipase. So those are lab values that we're looking at with the patient. You may also see some disorders with their calcium that may be low. Because even though you have the parathyroids that are responsible for regulating calcium, there's also the pancreas plays a role in calcium metabolism. So you can have patients who have problems with their calcium levels as well. Now, if this becomes a chronic problem, you will have patients who have diabetes from chronic pancreatitis. During the time that they have their acute phase, you can see their sugar go up and down all over the place kind of thing. But they can end up being a total diabetic if this becomes a chronic problem. So that's part of the reason why when you're treating the patient, you don't just treat them for the acute phase, because remember, they're usually dealing with a chronic disease and alcoholism. So yes, you treat them now to get them well, but you also have to do some counseling, Alcoholics Anonymous, treatment centers, that kind of stuff, because this stuff will kill you eventually when you talk about patients having pancreatitis. So some of the things that your patient, I talked about pain, they usually have tenderness. They may have bluish discoloration in the abdomen, and it's usually going to be around the umbilicus, so around your belly button, which is Cullen's sign. And then they'll have it on their flank, which is Gray-Turner sign. And how I always remember them, you turn around to see it, so that's how you remember Gray-Turners. So it's going to be on the flank. They have bluish discoloration there. So those things are telling you that the patient, those are symptoms that we look for, signs that we look for to see if the patient has pancreatitis. So those may be present in your patient. So Cullen's is a periumbilical blueness, and then Turner sign is on the flank area. Okay? So those are things that you look for in accompanying with the other symptoms that the patient is having. They have nausea, vomiting, you may have abdominal distension. All of those things are going on because of what's happening with the patient. So treatment is going to be, of course, we got an itis, so they get antibiotics. Anything in the GI tract when you're talking about infection is never one antibiotic. Okay? GI is different from any other spot because we already know we have gram-negative and gram-positive in the GI tract. So one antibiotic does not do it all. Yes, you give broad spectrum, and yes, they work, but you need more than one class. Okay? So unless the person is allergic, they get some type of penicillin drug. Okay? The other thing about penicillin drugs that you may have seen when you were in LPN school, sometimes they'll tell you to give the patient neomycin PO before they go to surgery, if you're going to have a colon resection or something like that. Not only does it provide antibiotic coverage before surgery, but it decreases the amount of bacteria actually in the bowel tract. So that's why penicillin drugs work better for this particular thing. So they get some type of penicillin drug, all right? They also get Flagyl, because Flagyl is antifungal, metronidazole is the name. They always get one of those. So that goes for any type of GI thing. You're going to see those two drugs. Then they usually add something else when you're talking about a patient that has pancreatitis. And it's the medication called Premaxin. Okay. So one of those things to kind of remember, Premaxin is never refrigerated, neither is Flagyl. So if your pharmacy supplies it for you, it's always on top of the refrigerator. If it's in a Pyxis machine, then it's never going to be in the refrigerated side. Okay. So whatever penicillin drug the person has, Flagyl, and then we also give Premaxin. It has a better penetration for the pancreas, so that's why they use it. It smells disgusting. Okay, if you get it on you, it smells like cat urine, oil, kind of thing. It's disgusting. All right. So patients get that, has better, like I said, better penetration, so it's actually able to get into the pancreas and get rid of the infection or the inflammation that is there. The other thing you're going to be giving the patient, of course, is pain medication, because that's what they want. Everything hurts me. I'm just going to die. Most doctors put a patient on a PCA machine, so you're not giving, coming back and giving them injections or giving them IV push meds. So PCA, they may have something that they do for breakthrough pain. There was a lot of controversy, and I think it's still in this textbook, about using morphine versus Demerol. And one of the reasons why Demerol was, for the most part, the opiate that we use for visceral pain. So anything you had, abdominal surgeries, those types of things, Demerol you would give to patients. You use it sparingly in elderly people because it has an active metabolite. So when it breaks down, it actually stays more active, so they get a cumulative effect, and you have people dying from narcotic overdose, essentially. But there was a controversy because they said the morphine actually caused spasms in the sphincter of Odie. And I'm like, who figures out all this stuff? But what they're saying is those spasms actually cause release of hormone and actually enzymes in the pancreatic enzymes and cause more pain for the patient. So over the last few years, they actually have literature that is written that says no, that's not the case. Looking back at retrospective studies, they're saying it's not as bad. So you will still see morphine used to treat pancreatitis for that reason, or you may also see Dilaudid used. Now remember, if your patient is getting Dilaudid, they are not equivalent. Yes, they are both narcotics, but Dilaudid is 10 times more potent than morphine. So you're giving patients who are, you know, like you're saying this person is getting 10 milligrams of morphine every hour because that's on their PCA machine, and then the doctor now writes for them to have Dilaudid 1 milligram. They're going like, why are you not giving me the same thing? Well, you actually are getting the same amount of medication. So sometimes patients, you know, especially if they've had this recurrent times, they'll even ask you, don't even put that morphine up, get the other one, kind of thing. And it's because it's a recurrent problem. What you don't, I talked about that if it continues to happen, they have chronic pancreatitis and then they can end up with diabetes. The other thing they end up with is problems processing fats. So that's a person that has to take pancreatic enzymes when they eat food. So that may be something that ends up happening as an end result if you don't correct the problem. So what you want to try to do is make sure that patient, you treat them during the acute phase, but also make sure they understand that you need to stop drinking if that's what their problem is. Drugs are the easiest one because we take away whatever it is. Because it's usually something we give people. It's not street drugs kind of stuff. It's something that we gave the patient to treat some disorder. So that's a lot easier to do. But if people are drinking, that's a little bit harder to do because you got to go about, you know, seeing a lot of lifestyle things that are going on. Doctors may consider doing anti-abuse therapy on the patient, whichever it is, because you got to keep them healthy enough to get better. Now the thing about this person can also lose a lot of weight, can be very sick, that kind of thing. So doctor may end up putting them on TPN. TPN is only used for this group if they're going to be NPO for a long time. If the doctors anticipate their amylase and lipase numbers keep staying up and not going down, because sometimes that can happen, because as the infection goes away, those numbers should gradually decrease. Pain should decrease every day. Those are things you're looking at to see if the patient is getting better. And if you have a person with protracted treatment times, then you're going to see somebody that possibly could go on TPN. Okay, because I got to keep them NPO for a longer period of time. So I have to be able to give them some nourishment by some other means. So that's why you'll see them go on that. But we really have to teach them about things you need to change in your life. You got to come off the alcohol because otherwise it just becomes a recurrent problem. It's like a revolving door. You pretty much see them in the hospital. The frequent flyers that come in with pancreatitis, and you say, oh, they're back again with the same thing. The other thing that you might see them doing, because we talked about pain is their major thing. Their pain tends to be relieved when they are in the knee-chest position. So they'll tell you when and they curl up like a ball, they feel better. So a lot of times you'll actually see them like that in the bed. With this one, it's usually a low-grade temp, maybe 100, and then they have a white count that's elevated that you see with that. So elevated white count, elevated amylase and lipase, pain, knee-chest position is how they feel. Better, those are things that kind of give it away. So nausea, vomiting may be present, abdominal distension may be present in that patient, so those would be things that they actually could have wrong with, or that you see on presentation. But also look at their history. Yeah?
What are the
Amylase and lipase. As they get better, you should see amylase and lipase go down too. That's one of the things we look at. Less pain, amylase and lipase going down. Of course, white count's going to go down. All of those things are being in response to treatment. Now I have a peritonitis down there, local and diffuse, and can kill you quick, kind of thing. So you know that's one of the bad ones. All right. The good thing is it doesn't happen that often. But peritonitis is an inflammation of the peritoneum. Okay, so all that stuff, all the lining inside your abdominal cavity is what you're looking at that happens with this patient. And the reason I put local and diffuse is because you can have a patient who has peritonitis just locally at the area where the patient might have had a rupture or something, or it can be diffuse all over the abdomen. That's the issue that you have with patients who have peritonitis. But it is an infection, and it's usually gram-negative because it's something we're leaking out of the GI tract that's causing the problem for the most part. It can be other stuff, but by far that's what you see most often. So you can see peritonitis occur after a patient has some type of infection. So you can see it with a person who has appendicitis, and that ruptures. You can see it in a patient who has a GI bleed or a gastric ulcer that ruptures. Because there has to be some opening that now comes into the peritoneal cavity, and it puts bacteria there. The reason that can be, if you think about the surface area within the peritoneum, is very large. So that's why your patient can be really, really sick. And we call it a hot abdomen. That's essentially what you call it when a patient has peritonitis. So this one can cause massive fluid shifts, volume losses from the vascular space into the abdomen. And this patient is septic, essentially. So you know how we talk about the white count of pancreatitis can be elevated? You're talking about a patient who looks like they have leukemia type numbers when you're talking about a patient who has peritonitis. 24, 25 when you're looking at white counts on patients. Okay? Because it's a lot of bacteria going on in there. And it's very bad when you see patients actually have this. So patient has a really high temp as opposed to pancreatitis, who has a slight elevation. When you're talking about patients with peritonitis, you're talking about 102s, 103s, 104s. So pronounced fever, okay. It's going to be pronounced elevation in white count that you see in these patients. They have abdominal distension, pain. Patient is very sick, okay. So remember, if they're losing vascular volume, blood pressure is low, pulse rate is high, because you're seeing all the signs of the shock in this patient. And it's because that volume is no longer available to the body to use. Now, if it's local, patient tends to have pain just at the site where they had the rupture. So appendicitis, that's why a lot of times you'll see it as little pockets, and it'll just actually happen around the area where the patient had the rupture. If it's diffuse all over the abdomen, then you're going to see a really large abdomen, and the patient generally has rebound tenderness all over. Okay, rebound tenderness is when I touch a person's abdomen. You know, they're hurting if you're not touching them, but when you touch them, they tell you, oh my God, it feels better. And then when you take your hand away, the peritoneum is rubbing against each other. That's what's producing the pain. So when you're just breathing everything, they're rubbing against each other all the time. When you hold them static, they're not moving. That's why they feel better. So when you take your hand away, they're moving again, rubbing against each other. Because remember, this infection is now all throughout the abdomen and in the peritoneal space, because you know anything that moves in the body has a viscera and parietal layer. So that fluid in between is no longer there. That lubrication is not there. It's infected. So that's why the patient has that rebound tenderness. Rebound tenderness is always something that needs to be evaluated by a physician if you ever assess it on a patient. They need to come and figure out, they become CSI then, to figure out why this patient is having this problem. Because that's usually a patient that needs to go to surgery. You need to figure out where this is coming from and fix it. Otherwise, you can have a patient die within hours. And the reason being is because the patient dies from septic shock in combination with hypovolemic shock. Because remember, they lose a whole bunch of fluid shift into the peritoneal space. So that's a lot of the edema or gastric distension you see in this patient. But they also, if you put an NG tube, have copious amounts of drainage. These are people that everything is shifting in their body, so nothing is available to the body that it needs to use. So therefore, you see all these signs and symptoms of shock, and then you have sepsis on top of it, because you have gram-negative somewhere going on in the GI tract. So that's why I say it can kill you within hours. If it's unrecognized, your patient will go downhill and just continue on. So early recognition is key. If you know you have a person come into the hospital that you're taking care of, or any kind of setting that you're working in, and they have appendicitis, you know, because sometimes we send them home, unfortunately. Nothing's coming up on the lab. We send you home. You go home. You're still having abdominal pain. You come back, and the person has a perforation. That happens. So those are things that if you have a person at risk that comes in, they know they had a perforated something, even though the doctors clean them out when they're in there doing their surgery, And a lot of times, not only they do their surgery, and then they also clean the area. They really do rinse it out with antibiotic-filled fluids to make sure they try to get everything that the person has. But still, everything doesn't, you don't always get everything. Okay? So sometimes you'll actually see that happen in the patient. But you can have a person that goes downhill very quickly, but it's because of those things going on. So when you don't have volume within the vascular space, the kidneys aren't being fed, so urine output goes down. You can end up in renal failure. You can have heart problems because you don't have the vascular volume there. So all the signs and symptoms of shock are going on with this patient, but organ systems are also going to be issues that you have to monitor the patient for. So with this one, same kind of thing as far as antibiotics go. Okay, we're going to do a culture of sensitivity because they got an infection. Then we're going to start them on antibiotics. So they get Flagyl, they get a penicillin drug. This person may also get, they don't get Premaxin, but they may get one of the aminoglycosides. So they may get a tobramycin added to the mix. Okay. A lot of times when you see peritonitis, they get 3 or 4 antibiotics, but those 3 are the general ones you see first. So some type of penicillin drug, Flagyl, and then tobramycin, and then based on cultures, they're going to do the culture track and see what they have to do, what's more specific to the patient as far as what they cultured out. Now, you got to keep the patient stable enough to actually be able to go to surgery, because if they're acutely ill, we got to stabilize them first before we cut them. The patient goes to surgery, and doctor takes out whatever it is that is causing the problem in the patient. In general, just remember, anybody who has anything that's infected will only get the minimum amount of stuff sewed up when they come back. And the reason I say that, they're going to have a drain, but everything has to heal from inside out. You never want to close a wound that is dirty, because what happens, all that stuff festers on the inside, and then you have to open them up again. So yes, they put in a drain, but usually you're going to see some type of wound you have to pack, because you don't ever want to sew up anything where something was dirty on the inside, as we say. The major reason being is if you cover that, if it starts to fester again, you got to open it again, and the patient has to have, that's another surgery for the patient. So we do what we call secondary intention. First intention means you do things on the outside, nobody sees anything. Okay, secondary intention means I'm going to have a wound heal from the inside out. So that's when you're packing things, pulling stuff out, and if it's an extensive wound packing, patient goes back to surgery to actually have the wound packing done, because you couldn't tolerate it being, I don't care what they do to you, how much medication they give to you on the outside, you got to go back to surgery for them to actually be able to do this wound dressing. I've seen them. They curl your toes kind of thing, you're thinking about what you got to do for this patient. So they actually go to surgery where they do the wound packing in surgery with the patient under anesthesia. Because that's how bad it can be when you have patients who have these types of resections. Now, the thing about it, depending on what happens or what they saw, you may see a patient who ends up with an ostomy or something that may be temporary. All kinds of stuff could have happened in there. But the thing about it is, you got to get all the bad stuff out in order for the patient to be able to heal. But very, very sick patient when you're talking about peritonitis. But what's kind of key when you're talking about GI stuff, both patients are going to have abdominal pain. Because when you think about pancreatitis and you think about peritonitis, both patients have abdominal pain. But a patient who has peritonitis does not have Cullen's sign, they don't have Gray-Turner sign. Okay. When you look at white counts, very high white count in peritonitis versus the patient who has pancreatitis. Okay. They both going to have pain, they both going to have NG tubes, but the sicker patient, unless they have fulminating pancreatitis, which you don't have for you to do, but is going to be the peritonitis patient. But it always tends to come from something that is ruptured within the abdominal cavity or some type of perforation, because those are the usual causative agents for patients having that. So also doesn't have that to go along with it. But the issue that you worry about is because of the fluid shifts and also because of sepsis. So it's usually bacteria or the combination of both of those things happening at the same time that end up killing the patient off. Okay, so that's why I put over there, kill you quick, because it can happen quick. Now, one of the other things that can happen for patients that drink, you notice a theme here, Coronas kind of thing. that patients who drink end up having these problems. So portal hypertension is actually a elevation in pressure within the portal system. The portal system is a very low pressure system, normally about 12 to 15 millimeters of mercury, if you actually measured it to see how much pressure is there. So patients who have increased pressure in that area usually are from patients who have right-sided heart failure, and because patients have liver disease associated with drinking. So cirrhosis, those types of things end up causing it for your patient. So what ends up happening is, because you have increased pressure within the portal system, it backs up into all those things that are fed on that side. So that means that the patient has hepatomegaly, splenomegaly. They always tell you they're feeling full, they're bloated around the middle, but that pressure also increases back into the lower esophagus. So the lower esophageal sphincter is what you're looking at when you talk about varices. The bottom part of your esophagus, right, that sits right above the stomach, essentially gets varicose veins. That's what happens. Okay, but remember, varicose veins there are very different from varicose veins in your leg, because stuff has to pass by it all the time. Okay, so this it thins out the walls of the vessels, so those varicosities are easy to rupture. So the walls get thinner and thinner, so that over time, if anything increases intra-abdominal pressure, will cause them to rupture. That's what you worry about with esophageal varices. So portal hypertension is the condition that leads to this is the complication, esophageal varices. So that's what you'll see. They'll talk about, if you look at the slides, talk about portal hypertension a little, but the main thing that you worry about when a patient has it is that they develop esophageal varices. And the major reason is because, like I said, it's essentially a varicose vein in the lower esophagus. Now what happens is the wall gets thinner and thinner, kind of like an aneurysm. It engorges itself, but the walls get thinner and thinner. So anything that increases intra-abdominal pressure can cause them to rupture. And if that happens, every time your heart beats, you're exsanguinating when you talk about patients who have varices. So it's a GI bleed that a patient has, but a different cause of why it happens in your patient. Now the bad part about this one is that if somebody doesn't witness it, every time your heart beats, blood is coming out. So if somebody's not there to help you, what happens to you? You bleed out. That's what essentially happens when you have patients who have varices. That's the major, of course, being dead is the major complication for everything, right? So, but that's one of the things that you're looking at for this patient. Now, what we try to do is, get them to stop drinking, because right-sided heart failure is different. We got to figure out and change some things that go on with their medications to try to prevent that. But the vast majority of people who have varices do drink. Okay, so you got to stop them from drinking. You notice that in the GI, a lot of the stuff has to do with alcohol. So patients have to be taught about that. But when you have a patient who has esophageal varices, you actually have to stop the bleeding. So doctors may go in and cauterize them. They may do ligation of a varice, so they'll put little bands on to make them, wither and die, kind of thing. You may also see a patient get a shunt, a portal hepatorenal shunt. Now this is to actually relieve the pressure within the portal system, and they have one in your book and one on your slides, transhepatic interjugular. I can't remember all the names of it. It's called a TIPS procedure. Ooh, that's a short name. All right. So they go in, and what they do is create a shunt that will relieve the pressure so that the blood flow and the pressure in that area is not as great. In your textbook, it will tell you that the TIPS procedure is done on the second episode of bleeding. So a patient has varices, they bleed it the first time, then they'll wait until the patient has the second bleed. In truth, patients who have esophageal varices and who have an active bleed are usually dead within 18 months. Okay. So the treatment of choice now is to actually do it the first time the patient has a bleed. So you're